Welcome, everybody. Today, as Brian talked about, our webinar is going to be covering filling care gaps for underserved patients with telehealth and focusing on application areas such as schools, prisons, and rural health hospitals. I'll be joined today by three panelists: Lisa Patch, the Executive Director of Health Services at Alamogordo Public Schools; Jason Povio, the CEO of Eagle Telemedicine; and Brendan Wilson, the Telehealth Analyst with YesCare. So we brought together this panel of experts on telehealth in some very specific application areas and care settings. So you may be wondering why schools, prisons, and rural hospitals. So just wanted to share with you our experience with our customers in these areas and what we've seen as some common challenges or other commonalities of what they face for delivering healthcare. So they have obviously similar populations served, meaning they have vulnerable patients with diverse needs. For example, schools have children that require support as they're developing and growing. Prisons have individuals with sometimes, chronic issues or complex situations, mental health. So there's a variety of needs in all these patient populations. And rural locations. So they all have, not all schools and prisons, of course, are in rural locations, but many are, including, of course, rural hospitals. So they face those common challenges of having it be difficult for staff and service providers to access funding. They all have resource constraints, whether it's for funding for telehealth technology or infrastructure. There's all those types of challenges that they face, as well as, of course, staff retention. And then policy and regulation, because all of these the government oversees when it comes to budgets and funding. So there's compliance requirements. So there's a lot of challenges that they face that we have seen. Telehealth has been a really great kind of a solution to help fill some of those challenges. So before we get started, I'd like to launch our first poll, which is just a question to help gauge the audience and what you're looking for out of today's session. So just give me a minute if you could just quickly answer the first poll question, which is, what type of information are you hoping to gain from today's session? Just a basic understanding of telehealth, or how to advance and or improve your current telehealth program, or neither of those? We'll wait a few minutes while this tallies, and this will give all of our participants kind of an idea when we are going through the different discussion points, kind of where you're at in your program. It's still going. Okay, I will. Oh, still going. People are still entering their response. Okay, I'm going to end the poll. And as you can see, about 19%, everybody can see this here. 19% of basic understanding of telehealth, and 81% are looking to advance or improve their current telehealth program. Great. Okay, so before we get started, I'm going to have each of our panelists introduce themselves to the audience, talk a little bit about your program, how many years you've been working on that telehealth program, maybe the specialties serviced, and what your role is there. Do you want to start, Brendan?
Sure will. My name is Brendan Wilson. I am the telehealth analyst with YesCare. I've been in this role for about 1.5 years, but the team I work with has been conducting telehealth in prisons and jails across the country for over 5 years. Some of the things specialties we deal with are cardiology, infectious disease, oncology, nephrology, orthopedic, wound care, and physical therapy.
Okay, great. Jason, would you like to go next?
Sure, thank you. Jason Povio, CEO, Eagle Telemedicine. We are a full-service suite virtual clinical service provider. We have been providing clinical solutions in telemedicine for the better part of 16 plus years now, and have expanded into 20 medical subspecialties. offering both acute and non-acute service offerings in the inpatient setting and an ambulatory setting across the great fruited plains, all 50 states.
Okay, Lisa?
Good morning and thank you. We are Alamogordo Public Schools. We're a rural public school system that we really needed to get care to all of our students. We have 195 homeless students, so this was a way to provide access to health care for all of our families and our ultimate goal of keeping kids healthy and safe in school. We've been in operation for 1 year now.
Great. Great. Well, welcome, everybody. All right, so today we'll get started with the first discussion point. And for those of you listening in, of course, along the way, go ahead and enter in the questions that you might have, and we will address them at the end, or if it's fitting, we can address them kind of during the discussion as well. So first thing we're going to talk about today is, of course, each of these care settings they present some pretty unique opportunities for healthcare delivery. And so can you each kind of go through what innovative solutions you have implemented to address these unique challenges in these environments, and then maybe what significant improvements you've seen from those initiatives? Brendan, you want to go first?
Yeah, so prisons obviously are a very unique environment all the way around. There's a lot of restrictive movement for inmates, and the goal is to get them care without them leaving the facility. We can't get surgeries done, but pre-op visits can be done via telehealth. Post-op follow-ups can be done versus telehealth. So that's one of our main goals. The biggest thing that I deal with is the infrastructure for our networks in prisons. Obviously, when they're built and designed, IT is never a forefront thought. It's always an afterthought. So one of the biggest issues we have, especially in some of our more rural locations, are just outdated infrastructure networks. And some of the ways we found in trying to beef them up, the cost sometimes isn't prohibited to actually go in, dig up new lines, put in state-of-the-art technology. So we've resorted to some satellite ISPs like Starlink to beef up the bandwidth so we can allow our patients to be seen. Another issue is the movement in prisons. It's not always guaranteed. There's kind of a three-step process. You have custody, which has to escort our inmates down to be able to be seen. We have nurses that will conduct the telehealth visit with the technology, and then the providers on the other end. This doesn't always coordinate well. So there has to be an understanding amongst everyone that, hey, could be a lockdown. So we're not going to be seen today. There's issues of that. But the main thing I would have to say is probably the network infrastructure is the biggest hurdle we have.
Okay, great. Jason, you want to go next?
Sure. Every facility that we engage with is unique in its own right, whether it's from a geographic perspective. I mean, there are a ton of challenges across rural America, of course, but urban settings aren't without their challenges as well. And so every facility is appreciated for its unique circumstances that have them investigating and evaluating virtual solutions to care for their patients in their community. One of the elements of that we've deployed is really a very fit for purpose approach to designing key workflows and infrastructural elements to support exactly those needs. And it takes a lot of time and attention with the clinical stakeholders to achieve that, but it's certainly the outcome is well worth it. We've developed a lot of key partnerships in the space to try to bring an all-encompassing solution to the table so that our clients enjoy the care that they're seeking for their patients to achieve the outcomes that they've set forth. And that could be, patient retention, reduction of transfers. It could be overnight care and services when it's really challenging to recruit and retain talent at night. I mean, it's just a variety of different things. I'll piggyback a little bit off of Brendan in that we too, I think one of the bigger challenges is from an infrastructure perspective, whether it's a technology or from like a Wi-Fi broadband perspective in some locations and facilities, and especially as we begin to expand the service setting and in starting to see patients in their home setting through clinics. That's kind of bubbled up a little bit more of having an appropriate broadband to make for a quality patient visit. So the infrastructure should not be underappreciated to ensure that you have an optimal clinical experience.
Great. Lisa?
Yes, and I have to also agree with them. The infrastructure is an important part of it. In our area, what we're trying to do is be able to allow parents to stay at work, so they are able to be on their cell phone or they can come in person, and really eliminating those things that can keep children in school. So whether it's putting the otoscope in their ear and diagnosing them with an ear infection while mom or dad are on the phone, they can get the prescription, child stays at school. Some of the other areas that we're looking at is, of course, we have an RN in every school, so they're able to do that assessment and have the standing orders with a local urgent care. So we can do the strep tests, the flu, the RSV, the COVID tests, so that we know what the results are and we know whether they can stay in school and whether the parent can stay at work. So that's taken collaboration with our local hospital and getting a backline set up with our urgent care. Urgent care seemed to be the easiest route to work with, but it decreases our equity issues for our families that don't have transportation. They can still seek that medical care, and we have those resources at all of our 14 sites. So and we're first year into it, so really working out all the permission slips and that the cross between education and healthcare has been the challenges that we've had, but are overcoming them. It is possible to overcome them.
Great. And for each of you, it sounds like a lot of these things you thought of ahead of time and you worked into the plan, but of course, as expected, you can't account for everything. Where there are a lot of surprises as you started to launch the program and move forward, that was, a big challenge for you to go back and fix it or change it? Okay. Great. So we're gonna move on to the next question, and we do have some questions coming in, so let me take a look to see. There's a question for you, Lisa, about what was the process for you to acquire the dollars necessary to implement this program?
We jumped on the bandwagon when COVID was in process and started looking at it then, and we were able to use grant monies to purchase the equipment.
Okay, I'll go through some of these. Okay. So now let's talk about clinical outcomes and key strategies for each of your programs. Can you share some of the specific clinical outcomes from your telehealth programs that have positively impacted patient care or overall health, and maybe some of the strategies that were key to achieving those outcomes? Why don't we start with you, Jason?
Sure. And I'll try to be brief because I could probably spend the next 30 minutes talking about clinical outcomes. I think one of the easiest outcomes to probably talk about from a virtual perspective in the acute setting is stroke. It's one of our largest services, and the ability to build out a comprehensive stroke program with or without local on-site resources and achieve door-to-needle times of not only sub 45, but even in many cases sub 30 minutes, and improve the efficacy of any TPA administration as a part of that program. Has been really enjoyable to see over the last few years. We've worked on some very creative workflows with where the technology is placed, when the physician would be triggered, and where the patient is ultimately assessed in order to expedite care and treatment, and then being able to add on a follow-up component to that from a general neurology perspective to support continued therapy and care plans for the remainder of their acute care stay. Has really been able to drive several clinical outcomes. And I'll share one more. I mean, ICU setting, the ability to partner with facilities in developing comprehensive staffing solutions and models for intensivist coverage to drive improvement in their leapfrog scores, to help support the care and delivery of patients that are at their most vulnerable, in a time that's very pivotal for them in that setting. So and being able to work on things like spontaneous breathing trials and spontaneous awakening trials, things of that nature, with caregivers there locally, nurse practitioners and nurses and such, to really drive care. Has been a hallmark of many of our programs that we design and develop.
Okay, how about you, Brennan? Clinical outcomes and key strategies.
Some of the clinical outcomes I think that we do are probably our asynchronous programs that we do for wound care and physical therapy. A lot of wounds can be open and untreated for a while, but having technology that uses a camera to take an algorithm to show the size of the wound, how to implement the proper bandaging, the proper time it would need, getting the bandages on sites to a person who may not necessarily be trained in how to wrap a bandage, but give them the skills to be able to, even if an inmate had to do it themselves. This allows us to monitor more effectively as well, so we can see the progress and see that they are improving over time versus not being treated, which could lead to other infectious problems. Also with physical therapy issues, we're partnered with a company called CareSpace that uses another algorithm asynchronously to measure the movement and give them exercises through telehealth to train them on how to do these exercises. And then, a week later, follow up to test the range of motion as well. That's one of the biggest things that I've seen with us.
How about you, Lisa?
I think our outcomes are still yet to be seen because we are so new, but really just getting the word out there and getting it people involved. I know one of the things that we hadn't anticipated was that we've had appointments where parents have been deployed because we are close to a Air Force base as well. And so that's been one of the nice things, is that they've been able to be involved even when they're not here local, and still be involved. So we're still working out the processes, and but we have been able to keep kids in school and get medical care for students that we noticed. That one of the main reasons we went this direction was we would have students that the nurses would send home because they needed to get medical care or bring back a doctor's note, and either they didn't have insurance or didn't have, they may or may not have told us. And so they just would miss a lot of school, where in this way, we're able to get that quick care for them and get them taken care of. In the process, we realized that it's handy to have a tech person there with the nurse. So we did hire an additional tech person to go to the school site and be there with the nurse, as well as a float nurse that's available if the office, because many of our nurses' offices are very busy. And so we can actually deploy the staff there to initiate the telehealth visit for the nurse, and if they're busy. So we're still working on the outcomes, and but it's been positive, and certainly been very positive with families and parents that don't have to leave work.
Lisa, you mentioned having a tech person. That's actually an interesting course strategy to kind of alleviate I'm guessing just alleviate any issues they might have connecting or technology. You want them focused on delivering care for the patient as opposed to the hiccups that happen with tech. That's smart. That's really, that's a
And
great
we want
idea.
the comfort level of the nurses to use it, right? Like, we don't want them to be afraid to play with it. And honestly, I have to say, when we first started, we limited the visits because we didn't want to become another urgent care, right? We didn't want them to send them to school sick for the telehealth. So we limited it to just certain things. But now that the nurses have become more comfortable with it, they're coming to me and saying, hey, can I go ahead? I don't think Johnny's going to go to the doctor, if we don't do this. Do you mind if I add this one? And so it is growing along with the comfort level of the staff. But I think you have to recognize that there's going to be that initial concern about, what if this scope doesn't work, or what if I don't know which button to push, or I can't hear somebody. So having that tech person stand there beside them has been really valuable.
That's great. It's good to hear. Actually, there's a couple questions for you, Lisa, specific to this and parent consent. So do you have any guidance on having the parents consent to these visits prior to the visit? And did you do paper consents or virtual? How did you handle that process?
So, yeah, this was definitely one of the biggest things, and we're starting the first full year. So it's a part of registration now. So parents can click on that when they're registering their child for school, and they can give us consent. We just need consent once a year, but in the consent, it does say that we are going to call the parent before a visit, and that there has to be an adult that is present either by phone or in person for the visit. So it can either be the parent or someone else they designate that's on the phone or in person.
Okay, great.
Mhm.
Brenda, did you already talk about your outcomes? Have we spoken some of the ones that you've mentioned earlier, or Brendan?
You talking to me? Sorry.
Yeah.
Yeah, no, same thing. Are we on number 2 or number 3? I was trying to respond to some of these questions.
The clinical outcomes and key strategies. So any outcomes you've seen?
Yeah, that's like I said, the main thing for us is definitely the wound care, the asynchronous stuff. Our main goal is to provide healthcare for these inmates while keeping them in a prison setting. And they will be creative to get out any way they can. So you'd be surprised. It's also kind of goes into the next question, if I could kind of kick that off. Is that okay?
Sure.
Okay, so in regards to implementing the specialty care stuff, let's say in a prison setting, you don't have to think about this in a rural hospital or a school setting, but how is the technology we're putting in there possibly used as a weapon? How can it be used to harm somebody? Let's take a tablet, for instance. If I'm putting a tablet in a prison setting, and this is something I've seen before, is they can break the tablet to get to the battery acid to harm themselves or others. So there has to be a thinking when we add a specialty care in there, is this going to, in the long run, hurt anybody? Is it something that can be weaponized? And as much as we think through it, we can never be creative as some of these people are inside jails and prisons. When we do a specialty program, let's say we're going to have a cardiologist, we want to make sure that we have a stethoscope or an EKG for them to use in regards to telehealth for live monitoring of patients. Same thing if we have a nephrologist, we're going to want them to have some type of sonar. I don't think implementing this without that kind of technology kind of hinders it in that regards. I think these integrations have made a difference. Like I said, we can't replace surgeries, but we can do a lot of stuff through telehealth now in regards to that.
With the medical devices being integrated and having them there if available, sounds like. Okay. Jason, what about you when it comes to implementing telehealth programs? I know you have a whole list of specialty areas that you cover. So how have you found, what have you done, I guess, to integrate medical devices into your point of care services?
Good question. I mean, evolutions continue to be made in this space. I was at a conference recently and was getting a demonstration on a device that is used in wound care to measure depth and other just elements of the wound to help facilitate the appropriate care or approach. And I'm fascinated by the changes that are taking place in this space. All of those advancements and improvements will only continue to drive improvement and facilitate more and more care from a virtual setting as appropriate. For us, each program is evaluated on its own merits. I think by and large, standard periphery would be a stethoscope. I mean, it's just kind of a standard part of a patient evaluation. And so making sure you have a stethoscope as part of your package. But we're starting to see a lot of adoption into all of the other different types of scopes, whether it's a varoscope, otoscope, dermoscope. We've cardiology, the ECG or EKG, 10, 12 leads that are out there are rather inexpensive over the long haul. And I mean, initial capital outlay may be a little bit of a sticker shock at $4,000 or $5,000, but for some smaller facilities, and I understand that, but the ability to live look and read and assess on an EKG perspective that and you do this through the actual hardware software platform of the telemedicine visit without needing or requiring integration into the EMR or having it from an EMR. It can be really consult altering as far as a plan of care. So, it's important to really assess what the core goals are of any program and what type of technology, including these periphery add-on devices, will facilitate in achieving those goals.
Makes sense. And then you can determine, kind of add on things as you need it, without over purchasing things that you may or may not need. And typically, we found the specialties, of course, like you said, will drive what that need is, right? If you're going to, when you start your program planning, what's medical specialties you're going to address, or at least start to address, and then you can build upon that as you start adding new services. And what about you, Lisa, when it comes to medical devices and integrating that into the, pediatric appointments?
Right. So of course the stethoscope for lung sounds and cardiac, but also we have the vitals machines attached, and the dermoscope, because kids are notorious for rashes that we don't know if they're contagious or what they are. So that quick call to the doctor can determine whether they can stay at school or not. So I think those are the vital ones that we like to have, and being able to look in the throat, of course. Looking in the throat and the ears is a big thing with our kiddos, and being able to get that diagnosis for them. So I did notice someone asked me about if a parent can't join, and I just wanted to say that they can designate someone else, but there has to be someone in that role on the visit so that they can follow up with any other medical care.
Great. Thank you. Okay, before I move on, I'm going to actually launch one more question for the group. Just kind of following on the question about medical specialties. So which medical specialties do you currently need telehealth for the most? Let's see, primary care, pediatrics, and you can check as many that apply for what you're looking for. Cardiology, dermatology, endocrinology, gastroenterology, neurology, and the list goes on. Of course, there's more, but.
Carrie, there's a question I can answer while people are reviewing.
Absolutely.
I can't find it, but it was something about correlation between access to care and quality of care and kind of a perception and a hybrid model. And it struck me, and I wanted to, because I think they're exactly right, or I think that's exactly right, is that one of the maybe misnomers out there is that telemedicine is in some ways a replacement, and it couldn't be farther from the truth. It's actually a part of, and becoming, and is an integral part of the overall delivery system. It's not a full-on replacement for all care. All right, and it should be looked at from that lens and what makes the most sense. Many of our programs are very hybrid in nature, with some semblance of on the ground visits supported by virtual means, and so I just wanted to touch on that because I think it's important to understand that telemedicine as a whole should be looked at in that way of how does it drive? How should you best develop your strategy to implement a telemed solution in addition to the care that you're already bringing to your community?
I agree, and it's like you said, it's a hybrid model. It's not one or the other, and it doesn't always lead with digital first either. We've noticed sometimes it complements it post. So we've definitely seen that change quite a bit.
Very much so.
Great, thank you for addressing that. So for the poll, I will quickly launch this. It looks like I've got a variety here. 48% for primary care. The largest one is just above that, 52% for mental health, followed by pediatrics and then neurology. So great, thank you everybody for participating in that. Okay, while we're at it, I know there's a couple more questions, quite a few more questions actually, so I'm going to hit some of them now before we go on to the last point. There's a question here for you, Brandon, about do you think prisons are taking advantage of telemedicine diagnostic prevention through yearly inmate checkups?
Yes and no. So we do have, most of our telehealth is done for specialty providers. We have on-site general practitioners at all the facilities either way. So they are getting constant checkups, constant care. A lot of it, we do some nursing through telehealth as well if we're short-staffed. I think everybody in this industry is struggling with the lack of nurses and providers. But I believe that they're getting proper care that they need in follow-up visits, making sure that they are getting, the meds they need, everything like that. So I would say yes in that regards.
There's some questions about access in rural areas with limited Wi-Fi, and I think you might all be able to speak to that one. So I don't know who wants to go first. I know, Brendan, you kind of touched on that as far as getting the infrastructure in place. So I'll let you start. Maybe if you have anything to add on that.
Yeah, I think telehealth outside of prisons is kind of falling into like a 5G kind of area as well, which doesn't work with us, unfortunately, because of our thick walls and the designs of prisons themselves. But we do sometimes, if we know they're going to conduct a clinic in a part of the prison that might have a window or some type of access to an outside tower, we would implement MiFi. And some of these structures that are in just deep rural areas where there's just no infrastructure whatsoever, we implement the Starlink for satellite ISP, which does surprisingly promote some really good speeds, which allow our clinics to go. A lot of what we do is in the mental health aspect, especially in prisons, with most people having some type of mental health issue coming in. So most of our clinics right now are on the mental health side. So luckily those bandwidth requirements aren't very high. So you can get away with lower speeds, but when we start implementing some of these specialty cares with all these peripherals and stuff like that, you're going to have a decent internet speed and bandwidth.
Okay, great. What about you, Jason?
Yeah, I mean, knock on wood, or thankfully, we don't encounter a ton of it because most of what we do is in collaboration with a hospital, with a clinic, and as businesses, they typically and do have really strong connections and connectivity. But as I stated, as we start to sort of wade into patients in the home setting, because of capacity constraints at some of the facilities, outpatient facilities, that has started to kind of pop up. And I know, I think it was maybe 3 weeks ago now, I'm trying to think that officially the federal program for broadband kind of expired, and there's not any new legislation that's on the horizon right now. This is kind of a more important topic. There are a ton of federal subsidies still out there, and there's state and local types of things. And I've even seen some of the actual providers themselves coming up with some really neat programs to help offset the overall expense. But I think part of the bigger part of the issue that still remains is just infrastructure. You just have some very large geographical dead zones that some infrastructure just hasn't reached, and still creates a challenge.
Great. There's a question here when talking about different specialties, and we actually didn't talk about this, but I know for schools in particular, Lisa, maybe you, Brendan, for prisons. How are you, if you are, incorporating the dental care or emergencies into the overall telehealth program? Is that something you've considered or you see a need for? Lisa? Maybe?
I'm sorry, I wasn't sure which one you were. We do have a program where we bring in dental hygienists into the schools. We haven't done anything with that through telehealth as of yet, but yeah, that's how we've had to address that.
Okay. What about you, Brendan?
For us, we're not doing anything with dental yet. We do have dentists on site that are usually there daily, so we haven't had the need for that yet.
Okay, great. All right, so we can move on to the next and final question around sustainability and scalability. And again, in each of your areas, what strategies have you found the most effective in addressing some of these potential failure points that we've been talking about, or failure points to growing the program or sustaining it? And how can these strategies, then be applied to ensure long-term success? Jason.
I thought you might come my way first. I'll address this from a bit of a technology standpoint, because the other half of what we do from a clinical workflow perspective, you're constantly feeding into evidence-based care and workflows and plans of care and therapies and things of that nature. But long-term sustainability for telemedicine is going to hinge on interoperability and the ability to seamlessly integrate or interface the disparate technologies that may be involved in the care delivery. And I would encourage folks out there that are looking to continue to advance is to really take a step back and take a hard look at your technology infrastructure. Far too often we engage with clients that are engaging with us because we provide 20 specialties, but they're coming to us because they need support in one or two that they can't find anywhere else. And while we're honored to do that, we're stepping into a situation where they have 2 or 3 other vendors, and in many cases 2 and 3 other technology platforms, and yet asking, well, what does your platform look like? And obviously we're a tech flex organization and can operate within any platform. But unfortunately, what we've uncovered is that others don't like to share their toys. So they don't allow for quote unquote competitors, whether they provide the specialty or not, to leverage their cart or to use their platform. So hey, we got to start looking at acquiring yet another cart, and the the alcove that's got all the wows in it now gets overcrowded with 2 and 3 different mobile carts and things of that nature, and it's just it ends up becoming a bit of a little bit nightmare. And so to the best of your ability to think through the most fit for purpose approach to your technology and software platform that can be a bit agnostic to the vendor you might be utilizing for your services is important. I think it's important for the long-term sustainability and viability of your ability to continue to deliver those services unencumbered by the technology side of things. So.
Great. I think that's a great way of saying it. Fit for purpose approach. I love it, because I think too many times, and I'm sure you experience on your end, your providers have to learn a different technology for each customer or each site if they had different, programs or different technology at each of those places. It's almost like they have to stay trained on all of that. That's got to be a lot to keep up with.
It is. And then not to get too detailed, but there's so many different types of protocols with the different types of technology. There's open architecture, closed architecture, invited in, it's open door, it reports session times this way. It's so varied and so different. You can find yourself, it's an unintended consequence, but you can find yourself in a situation where you're spending so much time just trying to manage the different environments from a reporting perspective, from a fleet management perspective, and it's just not worth it in the end. And so I think it's an important element and aspect to think about.
What about you, Brendan, for sustainability and scalability? What have you found to be the most effective for your program?
For us, it's open communication. There has to be, especially when the technology fails because of the infrastructure. Some of this can be weather affected too, in some of the states we're in, where the whole site will go down, and it can be very frustrating on both the provider end and the nurses end. Another aspect of it has to do with the training, making sure that everybody knows how the equipment works. I found that like a 3-step process of an initial setup, being on site, getting with one shift, followed by a conference style training, followed by identifying a super user and sending them out individually as a peer versus some IT guy or gal trying to train, has been effective in the adaptation of using the technology as well. And for us, that's been key in keeping it rolling, so to say.
Okay, great. Lisa, I know your program's still pretty new, but I'm sure you at least identified some areas. Yeah.
So about a year ago when we started, we brought in all the nurses and gave them opportunities to play with the equipment, to do visits back and forth with each other just to get comfortable with it. Then we brought in the urgent care providers and had the nurses and the providers meet each other so that they knew each other before, maybe to help with a little bit of grace as they work through it and build relationships, which can never be understated. And so we did that. And then just the continuing of having that tech person available. And I think as far as sustainability, the hospital has definitely, or the urgent care has definitely seen the advantages to it because their urgent care is less busy with sick people in the waiting room because they're at the schools, right? And getting taken care of. So we've been able to decrease the amount of time for the providers by taking the pictures with the equipment and having that all uploaded. So when the provider gets on there, they have everything they need to make a determination. And so it's a quick call for them. So as far as sustainability, the grant opportunities are there, as well as the collaboration with the medical facility to make sure that this maintains and continues.
Okay, we're going to move into the questions because we have quite a few that have come in. So we'll see how many of these we can get through. And let's see, Lisa, there's quite a few around the school-based program. One was about, you mentioned the grants. So what grants were awarded for your telemedicine equipment?
So there were some CDC grants that went through our state public education department and our Department of Health that we were able to use to get it started. That was the big expense to buy them all at once. Now through community schools, I think we're going to be able to replace equipment and update equipment and continue training for that part.
Okay.
I think there was a question too about whether we charge. At the school district, we do not. However, the parents are charged as if it were a regular urgent care visit at the site, at the urgent care site.
Okay, and you also mentioned you have a lot of quite a few homeless students, right? So
we do have, and so yeah, we have a social worker also that tag teams with us. So if we get a situation where there's not, if they don't have insurance, then we can do presumptive eligibility for Medicaid on site at the same time.
Okay. Another question, Lisa, for you is, are telehealth appointments available at the school or from home for students' family members?
So it's just for students and just at school.
Okay. So there is a question, I'm not sure, maybe Jason, this is something you might be able to answer or not, but just reimbursement or financing for service providers. So for physician service providers, is there reimbursement or?
So, I mean, so there is reimbursement. I'm assuming, I'll go with the assumption we're talking about for the professional fee component of the physician services that are rendered. You know, obviously, through the PHE, which expired last year, but there was the ability to bill, collect, and retain for professional fee services delivered through virtual modalities. But you know, a lot of that legislation was extended through the end of 2024. So when the clock strikes midnight, December 31st, you know, supposedly a lot of that will come to an end. However, I think the prevailing thoughts, and if I had money to bet in Vegas, which I don't, I would bet that you know, we'll see another extension of that legislation. There's a couple of key package legislation that's moving through some subcommittees now. I'm just not sure if it's moving at a speed that'll be voted on or brought to the floor and passed by the end of 2024. So you know, I believe wholeheartedly that there will be an extension with meaningful legislation to follow.
If any of you want to address this, or if not, if it's in a hospital or clinic setting, how can doctors effectively take patients' vital signs during a telehealth appointment?
So for us, I mean, that's either done, you know, if patients coming in, let's take an outpatient setting, they come in, they're roomed and by an MA, a CNA, a nurse, you know, part of any clinic visit, you know, patients their vitals are taken and either reported or integrated directly into the EMR. And as the physician comes on virtually for that visit, that information's heads up and readily available for them through the EMR. In the acute setting, you have a lot more remote patient monitoring types of devices. Most everything's lit up these days and integrated in some way through Bluetooth or whatever that just drops it right into the EMR for the physician to see. You know, I think the question might be more from like maybe a home setting perspective, but certainly if that's the case, and we don't have a ton of experience in that, I think that's a valid question to understand how patients could maybe self-take vitals through some technology means and be able to report that in to the physician prior to or during the visit. But I wouldn't have an answer on that.
Yeah, this was specific to the hospital or clinic setting, so you answered it, and I think to, you know, just add that obviously there's equipment that can take the patient's vital signs or can be manually entered, as Jason said, into the EMR, or it's integrated into the telehealth platform. So the device actually reads it, takes it, and automatically populates that into the telehealth session, which then goes into the EMR. So it's pretty seamless if you have the devices, the equipment, the platform integrated. It's a seamless process. So it can be done manually, but it can also be done through basically right through the telehealth platform.
Yep.
Okay. So what about getting a copy of the telehealth record back? So this dovetails into the EMR integration that you kind of touched on, but what do you try to get a copy of the telehealth record back to the primary care physician so that they have a complete record? So I know for you, Lisa, with the schools and the urgent care, that I don't know if that loop closes, right? So how did that get back to the PCP?
Right. So the urgent care is connected to the larger pediatricians group, and so they automatically get those records as they enter them. They will go into the students if they are connected to that pediatricians group. But they do use a separate laptop that they enter into their medical records, separate from the AMD visit currently.
Okay. Anybody else? All right. Key metrics for success. So there's been some questions around that and what you guys are using as those metrics for success, and it might be different, or maybe there's some common themes. Jason, you want to start with that one?
I mean, they're program dependent, but you know, to give some examples, it could be door to needle time for stroke. It could be thrombolytics, measuring the appropriate thrombolytics administration. It could be emergency department throughput time for admissions at night. It could be patient experience scores. Documentation and coding accuracy from a diagnosis perspective. So we have physicians that are measured based on their diagnosis accuracy. And we get reports monthly that report on our physicians' ability to capture appropriate diagnoses upon admission, right, upon initial presentation. As an example, sepsis, order set bundle compliance. I mean, the list, antibiotic stewardship, where we have really strong infectious disease programs, and what are we doing from an antimicrobial or antibiotic stewardship perspective. So there's a lot of different opportunities to measure success, but it is very program dependent.
Okay. Anyone else? Brendan, do you have any key metrics that you use?
For us, it's, making sure that we're utilizing telehealth as best we can in prisons. If it's something that we can do, let's say an orthopedic visit, that's going to be initial consultation. We can send the ortho the x-ray, we can have the video teleconferencing. So then we know that should have been done via telehealth versus sending them off-site. Taking them off-site definitely reduces custody on and can create security risks with an inmate of some stature being outside of the prison. So our biggest metric is making sure that we are utilizing it as best and just the most as we can. Yeah.
Usage. Okay. How about you, Lisa?
A lot of it is around student attendance, increasing student attendance, as well as decreasing the time for the office visits as we go along, trying to make sure that we're more effective and efficient in the process, and helping sick students get home, so that we don't have more sick students is really what we're looking at, is taking care of them and keeping the ones in school that we can. And parent satisfaction is always key.
Do you do surveys of the parents and families, or what have you? To?
Yes.
Is it are those surveys done after each care visit, or are they done annually?
It's done at the completion of the visit.
Okay. Great. There's a question about the university level from each of your perspectives. What key concerns do you see in the field which could be taught prior to care of the patient? So I'm guessing they're talking about anything that they can be added to the curriculum at a university for whether it's nurses or that would help with this process.
That's a great question. I know that telemedicine is being integrated into some programs, from what I'm hearing. I think, certainly that could certainly be expanded. We've kind of coined something. I don't think we created it or anything, but we've certainly got a term we've coined here called website manner. And it's really about an augmentation or a play off of bedside manner, but you've got to do it virtually, and you can't, you're not physically present. So the ability to sit down at the bedside, the ability to maybe place your hand on the patient's hand, little things that can go a long way to create comfort and a connection between caregiver and patient. You have to find ways to do that virtually. And how to present yourself in an appropriate manner, how to navigate the technology to create that optimal experience, both for yourself as a physician or clinician and for the patient as well. And so I think there could be curriculum developed and around that. And around how to effectively deliver clinical assessments through virtual platforms, I think would be pretty cool.
Okay. Great. We do have some more questions, and I know some of you are actually typing answers to the attendees, so I appreciate that. If you do have more questions, then please, feel free to follow up. You all will be getting an email after the webinar with a recording to this, and I will get the questions to each of the presenters, as well as the recording. So if you wish to watch it again or share with anybody else, you can do that. If there's anything else you guys would like to add, I think we can close out. We're at the end of the webinar. I'd like to thank everybody, and of course, thank the panelists and all the attendees for listening in today. Thank you and have a great day.
Thank you. Have a good day.
Bye.